Welcome, everybody, to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for May 12, 2022. Today's CME activity code is 485576. This conference is being recorded, and if you're not on our email list, please let us know. We'll add you to the list. They are recorded and uploaded by Dr. Baxi, and they should be available on our YouTube channel within a week or two of live presentation. Today we've got a great case. It's a case Dr. Gashti's, and I tweeted out earlier that it's his case, and wondering if we'll ever see a biopsy from him that is something other than acute interstitial nephritis, for which his dubious distinction is Dr. AIN. I also said that he wasn't on Twitter and called him a loser, and I think he took umbrage to that. And I just want you all to know that I do love KC Gashti like a brother. And it's all in fun, but I was trying to tweet shame him into joining Twitter, which I don't think he's going to ever do now. He'll absolutely double down and never join Twitter, but we're having some fun there. We have nothing to disclose, and to ensure patient privacy is preserved, identifying information, including age, gender, ethnicity, dates, exact laboratory values, and other details have been changed to disguise the identity of the patient and protect the patient confidentiality. Casey, are you reading it, or is Dr. Ramani reading it?
Yeah, I can read it.
Okay.
Yeah. So patient is a 43-year-old African-American woman with past medical history of SLE, which was diagnosed in 2010 based on positive ANA, RNP, alopecia, and arthralgia. She's not on any immunosuppression, including Plaquenil, due to concern for worsening heart failure. She also has pre-diabetes, nodular sclerosing Hodgkin's lymphoma, status post doxorubicin chemo, now in remission. Also history of non-ischemic cardiomyopathy, EF of 30%. Now she has recovered to 55 to 60%, thought to be related to chemo. History of fibromyalgia and unprovoked PE, negative hypercoagulable workup. So now she presents to ER with lower extremity edema, headache, and lightheadedness for 1 week. She also endorsed 5-pound weight gain over the past week. Denies nausea, vomiting, abdominal pain, vision changes, chest pain, or shortness of breath. No hematuria, frequency, or dysuria. She was recently treated for otitis media with Augmentin and ear drops. No recent viral infection, illness, including COVID. Denied use of NSAIDs or over-the-counter. She does not have any symptoms related to her prior lupus flare. On admission, she is hypertensive with blood pressure 160/90. Her serum creatinine is normal at 0.7 milligram per deciliter. Her urine has 600 protein on dipstick with urine protein to creatinine ratio of 5.4 gram per gram and urine albumin to creatinine ratio of 3.8 gram per gram. Her UA from 6 months prior to this admission was blend and had no proteinuria. Her review of system is positive for edema, headache, weight gain, but negative otherwise, including rash, no joint pain, swelling, alopecia, fatigue, weight changes, or night sweats. Her past medical history, as we mentioned earlier, SLE, lymphoma, GERD, PE, cardiomyopathy with recovered EF, hyperlipidemia, and hypertension. She's a former smoker, 1 cigarette per day for 2 years, which she quit in 2019, occasional alcohol and marijuana use, no illicit other drugs, herbal or over-the-counter supplements. Family history, she has 2 children, 15 and 20 years old, no preeclampsia or miscarriages. Her mother had hypertension and heart disease. Maternal grandmother had diabetes and sister with cerebral palsy. She's allergic to butalbital, acetaminophen, caffeine, had rash and urticaria. Her medications include carvedilol, omeprazole, and rosuvastatin. Physical exam, she's hypertensive with blood pressure 160/90, heart rate 78, she's afebrile, no respiratory distress, BMI of 35, and she's on room air. Patient on physical exam was unremarkable, alert, awake, no distress, no oral ulcers, cervical lymphadenopathy, no increased work of breathing, lungs were clear, heart exam was unremarkable, abdomen was benign. She had 2+ lower extremity edema, no skin rashes or joint swelling. Her labs Her sodium was 139, potassium 3.7, chloride 108, bicarb 25, BUN of 13, and creatinine 0.61. Blood sugar 77, total protein 5.8, and albumin low at 1.1. Calcium was 7.9, corrected was normal. Alkaline phosphatase 113, normal AST/ALT. Her albumin prior to this admission was 3.3. Her CBC was unremarkable, including WBC5. Her neutrophils were 35%. Hemoglobin was 11.2 and platelets 167. Her cholesterol was elevated at 302. Prior to this was 160 and LDL of 236, HDL 35, and triglycerides of 137. Her coegs were normal, including PPI and APTT. Her serologic workup, ANA was positive with titer 1:640. Double-stranded DNA was negative. Anti-RNP Smith was elevated at more than 8. Negative SSA, SSB, normal complements, including C3 and C4 at 172 and 43 respectively. And prior EPLA workup was negative. Her SPEP, UPEP immunofixation had no monoclonal protein. Infectious workup negative for HIV, Hep B, Hep C, and COVID. Her urine specific gravity was 1026, pH of 7, protein 600 on dipstick, no blood, no leukoestrase or nitrites. And her UPC-USC ratio, as we mentioned, was 5.4 and 3.89 gram per gram. Her ultrasound showed both kidneys were normal in size with echogenicity. Right kidney was 9.5 centimeter and left 10.2 centimeter in length. No focal lesions, stones, or perinephric fluid collection. CT chest was negative for PE, but it did report bibasilar in right middle lobe linear and subsegmental atelectasis, stable nodular opacity in right upper lobe, and enlarged right axillary and subpectoral lymph node. She underwent percutaneous renal biopsy.
Great. I think from this story, we're probably pretty safe to think this will not be acute interstitial nephritis. And with that in mind, we're going to run a poll right now to see what people think. We'll put this poll up. I want you to vote as what you think this patient has. We've got one possibility is lupus podocytopathy. The second would be a membranous class 5 lupus nephritis. The third would be minimal change disease. And the fourth option is focal segmental glomerular sclerosis. So your voting is anonymous, so please vote. We won't.
Nirali, when was the unprovoked PE?
That was a few years ago. I can look it up, but not recently. It was, yeah, many years ago. And currently she's not on any anticoagulation.
Give it a few more minutes here. You want some more votes in?
Interesting. Come on, vote everybody. We want to get a good representation.
There we go.
Coming in. Yeah, keep going. You know, somebody in the text just said options 1 and 3 are the same, and we will try to get to that. We will definitely talk about that at some point, because that's a very good question, and we would argue that that's not true, but that's a really, really good question. Okay, so the poll's ended. We've got 22% said lupus podocytopathy, 63, the majority said membranous class 5 lupus, only 11% said minimal change, and 1 person said focal sclerosis. So Pravir, why don't you walk us through each of these, walk us through the case, what you think about all of these.
Absolutely. And so, you know, first thing, whenever I see this, at least in lupus, you're automatically kind of drawn to something lupus related, lupus nephritis. But in the essence, when I see this patient has nephrotic syndrome. She has 5.4 grams of proteinuria, which is primarily albumin. So, you know, it's glomerular. Predominantly, she has an albumin of 1.1 with a lower extremity edema. So at this essence, a nephrotic syndrome. So I'm thinking the general differential for there is minimal change, membranous, FSGS, Of course, in her case, something lupus nephritis related, which could be the two options that we did have in the poll of membranous and lupus podocytopathy. Then I kind of look at, okay, did this happen over quite suddenly? What was the time course that she developed edema? And what we know is that it seems that she had pretty much a bland UA and no protein at least 6 months prior to this presentation. Then she all of a sudden started having 5-pound weight gain over 1 week, which seems a little sudden in onset to me. And that kind of leans me towards more of a minimal change disease, or, in this case with her background could be lupus podocytopathy, but and then less something like a membranous, which would be a little more over a little longer period of time. But, FSGS is another possibility with nephrotic syndrome, and primary FSGS can also present with kind of a sudden onset nephrotic syndrome as well, especially with certain FSGS lesions such as the tip lesion. So that's kind of, I'm thinking kind of broadly in the broad sense. Then I look at her, a couple other clues to her HPI and physical exam. She's hypertensive, 160/90, although she's only on carvedilol, which I assume is just for her prior heart, for her cardiomyopathy, but she's not on any other hypertensives, but she is hypertensive. Her BMI is 35.6, so she is obese. And then on her other laboratory work, her cholesterol is quite elevated, which again, other clues for me leaning toward minimal change disease. And then finally, her serological workup, her complements are actually normal, and her anti-double-stranded DNA is less than 1. SPEP, UPEP, of course, we can think paraprotein-related amyloid or other paraprotein-related lesions causing nephrotic syndrome, but that was negative, and that was less likely based just on her age and other key features in her history. And then her UA, finally, I look at the UA, and really there's no blood, but it's primarily protein. So really inactive sediment, but she has nephrotic range proteinuria. So then I start to narrow it down, and I'm still, lupus is always on there. And with her UA, I would lean against, a proliferative lesion due to the lack of blood and her normal creatinine of 0.6. That would lead me away from a class 3 or class 4 proliferative lesion, but minimal change, as well as membranous lupus, as well as lupus podocytopathy remains on the differential. Then she also, and that's in terms of the lupus aspect, she also has this history of Hodgkin's lymphoma, and we don't have any, she's in remission, but then her CT has some, interesting lesions of, large lymph nodes. And maybe she's having a relapse of her lymphoma, and that would lean me more towards minimal change disease. Other things, in terms of FSGS, secondary FSGS, given her obesity and hypertension, but she's not hypertensive at baseline. And secondary FSGS wouldn't kind of present with sudden onset like this. Primary FSGS could, but I think I would put minimal change or lupus membranous or lupus podocytopathy above that. And I would put minimal change above that too. And I think that was kind of the broad differential for me. So if I had to list my top 3, I think given her kind of sudden onset of weight gain, some CT findings here, even though she's hypertensive, I'm leaning more towards a minimal change disease, and it could be secondary to Hodgkin's lymphoma. Maybe her lymphoma has relapsed. Number 2 would be a lupus-related lesion. And again, even though her serologies are more or less normal, you can still see membranous lupus and lupus podocytopathy. I would tend to put probably lupus podocytopathy 2, just given otherwise lupus-wise, her UA is bland, her other lupus symptoms seems to be not really flaring. Membranous lupus, I'll put 3, and then I'll put FSGS 4. And I would think of it would be more of a primary FSGS versus a secondary FSGS.
Great. So you said my top 3, and that there were only 4 in the poll.
I know. I added
so
a 4.
What is your number 1?
My number 1 would be minimal change disease,
Okay.
just given the abrupt onset. It was 60-40 for me, minimal change versus a lupus podocytopathy. But with the abrupt onset and the lack of other systemic lupus symptoms at this time, I think in the CT findings, I'll go with minimal change from potentially a lymphoma flare.
Yeah, the lack of systemic symptoms doesn't bother me as much because we'll see that in class 5 lupus. But I have to agree with you when I think about this abrupt onset. The level of proteinuria seems a little bit low for the albumin, but we've seen that too. And I'm not going to make too much out of that. So I'm surprised 2/3 of people just put lupus membranous down as the top diagnosis. Doesn't mean they're wrong. I'm just saying what I would think. I really find this abruptly kind of predictive of more of a podocytopathy. Steve Corbett, can you walk us through the history and kind of a little bit about this podocytopathy? And is it the same, or is it minimal change disease in lupus? You want to unmute yourself, Steve.
Did Casey mute me again?
Oh, you muted yourself this time.
So I think that, the likelihood is there are probably two different things. I don't know that we know what the factor is still in minimal change disease per se. I mean, they quote the paper from years ago, I think it was Shalab, I'll probably be saying the name wrong, with thymoma and the associated minimal change disease. But again, I don't know that anybody's found that particular factor any more than we know for sure what the factor is in lupus. But I don't know that I doubt that they're the same, but I don't know how one would differentiate it other than the fact that patients with lupus will have other manifestations, either immune complexes in the mesangium or antibodies such as this, where they have low level ANA. I think if you have somebody that has lupus, it's kind of hard to call them idiopathic minimal change disease. Although in the past, there have been papers that were published that suggested that there were two things going on at one time. I think that more likely than not, this is just another manifestation of lupus. And we know that, lupus can manifest itself in many ways. I mean, the antibodies that cause membranous are different than the antibodies that cause diffuse proliferative. And the situation that leads to a thrombotic microangiopathy, is yet different again. And I think this is just one other manifestation of the immunologic craziness that goes on in these patients that we can't always define. So I don't know that I don't know that we'll be able to differentiate, but I would think that in a patient that has this history of lupus and it has the serology such as this, that if there is a podocytopathy, I would attribute it to the lupus. That said, the treatment is the same. And I think that was, one of the big conundrums in the patients that had lupus with membranous was that many of them were on NSAIDs. So there was a period of time that the concern was that this wasn't really a podocytopathy from lupus, but that it was minimal change from NSAIDs. And then Jerry Appel and their group published some cases, and I think Steve Kraft with us, we had our own series. I mean, many of those patients, from my recollection, again, had immune deposits in the mesangium, but had diffuse foot process effacement. So, I mean, mesangial lupus usually doesn't cause nephrotic syndrome in and of itself. And so these patients that have nephrosis with mesangial deposits generally have this podocytopathy. I can't remember the name of the lead author in the Jerry Appel paper, but I know Steve, our fellow, geez, I can't believe Kraft, came out, looked at our series.
Yeah, it all started with these lots and lots of reports of minimal change disease in patients with lupus, and they thought that that somehow minimal change was more likely to occur in lupus. And I think it was Dr. Lewis that actually coined the term lupus podocytopathy, and it's caught on like crazy. It's really a wonderful term because it does imply that maybe there's something pathophysiologically about lupus that's affecting the podocyte and leading to this abnormality. But I think what these cases were, they were cases, as you said, with underlying mild mesangial lupus typically that have severe diffuse foot process effacement. And the question is it a different pathophysiology or not? In my experience, these patients, the treatment is the same, but my experience is they don't respond quite the same way as an idiopathic minimal change disease. And I know our group has always been strong proponents of the many different pathophysiologies of glomerulonephritis. It's not one thing, there's like, as Steve mentioned, there's membranous, there's diffuse proliferative, there's pauciimmune, which is a whole nother we believe is another pathophysiology because you don't see antibodies. And it's very possible that something else is going on with the podocytopathy, which is what Dr. Rubin kind of brought up, and I was going to talk about, but I'd rather Mario, why don't you elaborate on your post in the chat?
Well, I mean, I agree with Steve. I mean, histologically, I don't think you can tell them apart, except for the presence of autism in cases of lupus. But the recent work by the group at the Brigham regarding the discovery of anti-nephrin antibodies, in some cases, not all of them of minimal change, raises the possibility of using that test for diagnosis of minimal change. I mean, there is no data, to my knowledge, following the titer of these antibodies with respect to response to therapy like there is for PLA2R in membranous. So, I mean, it's just another diagnostic tool that is not yet ready for prime time, but stay tuned.
Yeah, that's well put. I don't think it's ready for prime time, but it's very exciting. You know, I hope it pans out as PLA2R. I kind of don't think it's going to be as strong because I think it was in their series only about a third of the patients had anti-nephrin antibodies. But who knows? Maybe it'll play out like PLA2R, and then we'll find 4 or 5 other, like similar to anti-nephrin antibodies that are causing minimal change disease. But that is what's really interesting here, and I hadn't thought about that until 5 minutes ago. The fact that if we do identify anti-nephrin antibodies, and since lupus is an autoimmune disease with a lot of antibodies, and I was making the case for it being yet a separate pathophysiology, that it'll be really interesting to see if patients with lupus podocytopathy have anti-nephrin antibodies. So that'll be a fun thing to figure out. Steve, what was your number 1 diagnosis?
Minimal change disease due to a relapse in the Hodgkin's disease.
You like that?
Everybody was kind of been jumping all over this lupus. Is making me nervous. I'm glad Pravir finally got around to the Hodgkin's disease. Ed Lewis would probably be turning over if no one had brought that up.
Well, Steve, the term is usually turning over in your grave, and Ed's not dead yet. So
no, I'm saying turn over in his bed. He's probably not out of bed yet.
I'm just having fun.
But yeah, I mean, this person clearly didn't present with nephrotic syndrome at the time of Hodgkin's disease. But when Ed wrote that paper with Jerry Egan, that editorial, I know everybody focuses on solid tumors, but they also talked about Hodgkin's disease and minimal change. And the overall landscape of that paper basically said, made the point that, nephrotic syndrome pre-exists the finding of these tumors, whether they be solid or hematologic, around 40 or 50% of the time, the nephrotic syndrome occurred 6 months before the malignancy was ever basically discovered. And about 20% of the time, they were basically discovered at the same time. So that basically, somewhere around 60, 70% of the time, the nephrotic syndrome preceded the discovery of a tumor. But about 30% of the time or so, they'd already had known tumors and then developed nephrotic syndrome. And so, the fact that, I guess my point is the fact that this person didn't have nephrotic syndrome when they first presented with their Hodgkin's disease, and I'll assume they didn't because I think that would have been a big issue that would have been in the history, doesn't mean that it still couldn't be, herald a relapse in the nephrotic and in the Hodgkin's disease. And for sure, when the CT scan was put up there, and there are these axillary nodes and subpectoral nodes, I'm thinking, how can you not, wonder about that as much as the lupus, if not more, because that would portend an even bigger problem, not just their minimal change disease, but that she's got a reactivation of her or a relapse of her lymphoma. So that truthfully, that was as this whole thing evolved, that was my first thought. Maybe just because that paper and that, that's just kind of one of those things that's always out there that I don't know that we've seen it that often, but it definitely comes up. Lupus for sure, but I think that's got to be up there in the top 1 and 2. And for me, it was number 1.
1 and 2. Well, that's good.
But one being this, lupus being number 2 with minimal change. I have to admit, I think you alluded to this. To see this kind of sudden onset, not a nephrotic syndrome, but this kind of hypoalbuminemia is kind of unusual for membranous. You can, we've seen it. I mean, stranger things have happened, but this is a really sudden onset, profound nephrosis, and the idea of minimal change, be primary or secondary. FSGS, I think it was alluded to, whether it be, I doubt that it's collapsing with a creatinine that good, but a tip lesion, I guess, is possible, even though it's less common in African Americans. I think those things are far higher up, for me at least, than membranous, only because of the presentation.
Yeah, well, it's funny because I'm a big fan of Occam's razor, and this should be one disease. This should be lupus with nephrotic syndrome, whether it's podocytopathy or membranous. And I agree that seems pretty abrupt. But Hickdom's dictum says a patient can have as many diseases as they want, and so I think a lot of people are going with Hickdom here, and I kind of have to agree. I think that membranous lupus is not the highest on my list here, but we're putting a lot of weight on the abruptness, the high cholesterol, the severely low albumin, etc. I think.
So what are the two disconnected lesion that what are the two disconnected diagnoses that you're pulling together?
She has lupus, and then she has lymphoma or something. She has lupus or idiopathic minimal change.
Gotcha.
She has a second disease on top of one disease. I mean, it should just be lupus, but that's what Occam would say. Let's get the biopsy wheel going here and see who reads the biopsy.
We really have to get music.
I can sing, but I'd probably get fired from this job. Might as well continue, Pravir.
Yep. I'll give myself mouse.
You're on a roll. Yeah, give yourself the
I'll give
mouse.
myself the mouse.
You better not.
All right.
You better not screw this up, or you're in trouble.
Pressure's on. All right. So we went over the poll. Here we go. David, you on?
Yeah, can you hear me?
Yep. So we have a low power trichome stain looking. We have multiple glomeruli on this sample, and actually looking for kind of interstitial disease, chronic disease scarring. With the creatinine at 0.6, with this, we weren't expecting anything. And here, I mean, I don't see, it looks really minimal, less than 10%, if any, probably less than 5%, maybe, David, if you can say that.
Yeah, I agree with you.
I never see
minimal.
usually you see the increments of 10 or 20, but, and then the glomeruli at this power, again, we'll wait to see a higher power, but she did have lupus. I don't see, we're not expecting a proliferative lesion, and, I don't see at this power any crescents. Interstitial with that amount of nephrotic syndrome, sometimes we get interstitial edema, but I don't see really any blue staining material. So I'll go to the next slide. This is a PAS stain. We have one glomerulus right in the center of the stain. I actually have two. We have one glomerulus here and another one over here. Let's see. Mesangial, maybe very mildly expanded in some, say, segmental areas of proliferation. Otherwise,
Right. Yeah, I agree with you. Right there in the middle, I see
Yeah.
like 4 mesangial nuclei. So
I
yeah,
was trying to see where the hilum was, but I don't think we're above. So I don't think that's the hilum. And the capillary loops all look open, nice, thin, and delicate, at least at this view. Maybe that one a little, but in terms of our differential, we have minimal change disease, membranous, FSGS. I don't see any segmental lesions in this glomerulus. Otherwise, really not much except a little bit of mesangial expansion and hypercellularity. We have a kind of a glom kind of hanging out here. Looks pretty normal, actually. I don't know yeah, pretty normal
yeah.
from what we can tell. We don't have the other half of that, but that's pretty much normal. Interstitium,
Yeah, the
Really?
tubules look good. They have brush
yeah,
borders.
tubule looks good. Good brush borders. No evidence of ATN.
Yeah.
High power H&E. We have one glomerulus here. You can see a little bit more of mesangial expansion in this glomerulus that is a little more pronounced. Some areas of maybe really not hypercellularity, just a little bit expansion. Loops look open. I don't see any segmental lesions in terms of FSGS. Membranous, again, we sometimes see that kind of rigid tube of capillary walls, but really we want to wait for the immunofluorescence and EM for that. So in minimal change disease, again, that so far on this one, really all we're seeing is a little bit of mesangial expansion. So I think everything is still, at least FSGS is seeming less likely until we get more the sample, but I think minimal change can still be on there, although the mesangial expansion would have to see the immunofluorescence, and then membranous, of course, would still be on there still too. Interstitium wise, looks like you have a artery over here, David.
Yeah.
Yeah, looks no sclerosis.
Yeah.
No interstitial nephritis, despite this being Dr. Gashi's patient.
Okay.
So silver stain. Wow. So if you look, it kind of just jumps out of the screen. So we have one glomerulus here, and I can already see before I move on, you see all these holes, right in the enfas. Right
Yep.
there. And then, I mean, so tons of holes. You have actually some, I don't know if this is too, I mean, I really want to look at the outside wall capillary.
Yeah.
loop
So
and
look
the
at like
holes.
2 o'clock.
Yeah. Oh, right there. Right
yeah.
here. Really nice.
There you see some spikes. Yeah.
So a lot of spikes and holes, which again correlate with what concern for membranous, which was on our differential. There's no other breaks or any other type of lesions in this glomerulus. So the biggest thing here is really concerning for membranous now, and then we'll see what the immunofluorescence shows. So this is IgG, and wow, it's really positive. And it's primarily granular in the capillary wall loops, which would be, again, consistent with membranous, membranous. And then this is IgG. There you have maybe some in the mesangial too, right? Mesangial deposition of IgG. But primarily the biggest thing here is granular staining in the capillary walls.
Yep.
David,
So
is that enough? David, is that enough for you to feel mesangial as well?
Yeah. I think that one area he pointed out looks like they're embedded there in the mesangial area. And of course, having known what the EM is going to show, that kind of biases me. But typically in membranous, it is hard to say if it's mesangial or not. Yeah, because many years we've said capillary wall and mesangial, and it turns out it's just capillary wall. So
now
So David, what was the rest of the IF?
So the IgG is strongly positive. You can see here the IgM was 1+. There was no IgA. There was no C1q either.
Okay, so I have a question, Pravir. How do you feel about your diagnosis? How about you feel about the diagnosis of lupus membranous? Let me put it that way.
That's a great question. Usually, typically, we see a full house pattern with the IgA and the C1q. And so, I would kind of question a little. We see the EMs. I mean, the EMs would be very helpful here to see, are we seeing a lot of mesangial deposits? Are we seeing TRIs? And then if we see some of those, I would feel more comfortable saying this is still likely, lupus related. But, membranous can be non-lupus and idiopathic, or really now we don't call it idiopathic, PLA2R, depending on the antigen. PLA2R and other antigens, and in lupus there's a few other antigens as well. So I don't like that it's not a full house, especially with her lack of lupus symptoms systemically, and her serologies, although we can see it in lupus membranous, her lupus serology is still being quite normal, and then just her presentation. So I would question, maybe is this more, I would like to see a PLA2R, really. PLA2R, that would be helpful, even
David,
though...
Do we have that, David?
Yeah, at this point, I did do the PLA2R because the fluorescence was not full house. It was weakly positive, I don't have a picture to show it because when it's weak, the camera that we have doesn't pick up the faint intensity, but it was weakly faintly positive.
JC, I forgot. Do we have a PLA2R in the blood?
That was my next question.
No, we don't.
We don't have a PLA2R in the blood.
Mhm.
So
and-
just Prevere. I mean, with that information, what would your diagnosis be? That's all you got today.
That's all we have today. We know it's membranous, and with its weekly positive, oh man, I if that's all we have, if we have the EMs and like I said, we have mesangial.
All you have.
That's all. We don't have EMs. Oof.
Yeah, the EM's on the way.
David.
No, with no DMs, right? No
I'm
EMs.
asking him at this point.
Yeah, at this point, with a weekly positive PLA2R and still with all this lupus, I would lean towards still lupus, because there are some cases of lupus membranous, lupus membranous that can have PLA2R positivity.
So you're not biting at all. I'm saying there's something wrong about this, because certainly the IF is full house typically, but when do we see non-full house with lupus membranous? I don't know the answer to that, but it just seems very odd to me. The mesangial hypercellularity was minimal, and we will see the EMs. But I wanted to get to this point, and you could have a negative serum PLA2R and a positive tissue staining, especially if it's weak like this. It may just be a sink for that, and it doesn't always correlate. You could have a little PLA2R and have membranous and a very small titer of PLA2R. So I don't think that's out. I mean, I think that the diagnosis of PLA2R membranous is still, and Dr. Corbett brought up, of course, be nice to know about the exostocin as well, because that's a very common antigen that's seen here. But what we have is a PLA2R and negative immunofluorescence. So I couldn't make you buy that, but that's where I'm putting my nickel down if I had to at this point.
The only
Remember,
other
the PLA2R that you're measuring in the biopsy is not the antibody, it's the antigen.
I understand, but it's usually only positive when the antibody's there. It's a good point, but it's still, we don't see it in other things typically, unless the antibody has somehow exposed it.
Now, Roger,
Yes.
I think we have discussed in this biopsy conference before, and it's also in the literature, that membranous lupus usually is associated with a paucity of serological and immunofluorescent findings. So what we see here is not unusual for membranous lupus.
Well, I know that. I mean, certainly serologically, but that was really my question. We only have IgG. We have nothing else. No C1q, nothing else. Now, I know the clues that point you towards lupus membranous is when you have C1q, when you have IgA, or you have C3 or something else, or you have mesangial deposits, or you have mesangial hypercellularity. But does the lack of that kind of take it away? Steve, you've been shaking your head. What's your thoughts on what we're on Ruben v. Rodby?
No, I mean, Mario's right. I mean, this whole issue of latent lupus nephritis is oftentimes it was membranous. I mean, they were looking for subtle clues, and you needed all three of them to basically make the diagnosis. The lack of any one, excluded things more often than not. But I mean, usually the things they were looking at is, as you've already alluded to, mesangial hypercellular, mesangial deposits, subendothelial deposits was the other thing, tubuloreticular structures. The whole issue of full house is nice if it's there, but the fact that it's not there doesn't rule it out for sure. And C1q you'd like to see, but I don't know that that's necessarily a in membranous, especially something you necessarily have to see. I mean, C1q is definitely important, I think, in the proliferative forms of GN that we see with lupus that are IgG1 and IgG3 mediated, but in IgG4 mediated, which is basically lupus membranous, I don't know that the C1q is necessarily a deal breaker, and it's not one that I've necessarily seen when we've talked about latent lupus membranous. I think this is still, membranous lupus is still high on the list in this patient. I mean, we'll see what we see on the EMs, but
that's great, because I'm clearly outvoted, and I will accept that totally. I put too much weight on I'm basically putting too much weight on the IF. So let's look at the EMs.
So we have, just to orient ourselves, we have your blood space here, and then you have urinary space here. We'll start with this loop here. You can see several deposits. This looks intermembranous, but primarily epithelial deposits, and you can see the quite nicely here, quite large too, and it's kind of diffuse. I mean, it's not just kind of scattered; they're kind of all over. They've seen primarily still subepithelial. None, they haven't. There are few that have gone intermembranous, but this still seems like an early, still pretty early. In terms of, and then kind of moving on here, kind of similarly, a lot of, and I don't know, David, these are some more
Yeah, I still
intramembranous-
consider those intramembranous.
membranous, yeah, rather than subendothelial deposit. Again, this is your blood space, urinary space here.
Any mesangial?
Mesangium here. I think you have maybe some deposits here,
Yeah.
right? Not a lot, but there's definitely there are deposits in the mesangium. In terms of your podocyte, it looks pretty diffusely effaced here. Diffuse effacement. I mean, there's very little areas of preservation.
Yep.
Maybe here, but otherwise really diffuse effacement of the podocytes. And then you have RBCs there.
Okay, good.
No subendothelial deposits. Nice. We'll start again, blood space, urinary space here. You have some subepithelial deposits, and actually you have a few intramembranous as well, but no significant and subendothelial deposits really. Then you are looking for TRIs. Is this a TRI right here?
No, those are little
Oh,
mitochondria in
mitochondria.
that endothelial
Okay.
cell.
So no TRIs so far. Podocytes very effaced. I guess there's some little here that's still preserved, but otherwise diffusely effaced that we've seen so far. Another EM, blood space, urinary space, multiple subepithelial deposits. Now, some of these are
These are all
subendo.
endothelial.
Yeah, you have some subendothelial deposits here. In diffuse effacement of the podocytes. I don't see any TRIs that we've seen so far.
Now, Pravir, I mean, do you think that there is some flocculent material in the subendothelial location there? Like you
Right there. Yeah, that does seem kind of
funny. I mean, when I see that, I think TMA, but certainly this is not the case. David, can you please comment?
Well, I think that's just the endothelium reacting to the presence of the deposits there. It does look a little light colored flocculent, like you said, but I didn't see any evidence of TMA or anything like that in the biopsy.
Okay.
Thank you.
I mean, it's impressive how much intramembranous, how many intramembranous deposits. I mean, it's hard to know how sudden this occurred, but this looks like it's been there a lot longer than just, the last month or so.
Yeah.
All right. So what are we looking at here? You point nice. So thanks for the arrow. Looks like a TRI right here.
Yep.
So we do have a TRI, and then you have another, I guess, two loops here, blood space, urinary space, and you're just seeing a lot more of subepithelial deposits, diffuse podocyte effacement, but the biggest thing here is a TRI. So diagnosis, putting this all together, I would put this as lupus membranous. That would be my diagnosis. And then we can talk about the PLA2R and see what the serum was negative, I believe, or we didn't have it.
Yeah, it was negative. Yeah, so the audience was right. 2/3 predicted it properly. I tried to lead everybody astray. I led myself astray with the immunofluorescence, and I think we have Occam wins in this case. Casey, you want to tell us your thoughts? Oh wait, let's do a quick poll. Well, we have a poll. Let's how would you all treat this? So we have 4 options: MMF, rituximab, steroids, or a cyclophosphamide-based protocol. I'll tell you, originally I had CNI in there, but I don't like 5 choices. And CNIs are kind of not as popular anymore. But it would be reasonable to add that as a fifth option.
Give it a few more seconds here, please. Come on.
So when I say steroids, I'm really talking about steroids alone. And then MMF could be with or without steroids, but basically, I think you guys get the idea. Good. So we have about half the people picked rituximab. The second most popular was MMF. Steroids at 17% and cyclophosphamide, 2 people voted on. So a nice mixture. It's interesting how rituximab, how popular rituximab is becoming for treating almost everything, with relatively not a lot of data for this lesion. Even though I wouldn't disagree with it. Casey, you want to walk us through your thoughts and what you did?
Yeah, this as the discussion kind of went on, I I was just thinking back about when this patient presented and how the case really evolved, because as Dr. Corbett said, when I first met the patient, I was pretty convinced she had minimal change disease. She just showed up with a week of being swollen, and her albumin is 1 and her cholesterol is 3 times higher than it was before. And these lymph nodes on CT, I was pretty convinced this was minimal change disease. I was so convinced I even started her on steroids before I biopsied her, just for a few, because it was a Friday type of thing and biopsy wasn't going to happen until the following week. And I said, well, what's the harm in starting steroids for now? So then we get the biopsy back, and initially the EM takes a few weeks. So we have light and fluorescent. And so the diagnosis at that point is that she has membranous, not a full house, and a weakly positive PLA2R in the tissue. So I'm like, okay, so this looks like, well, surprise, it's not minimal change. It looks like it's primary membranous. So then I'm like, all right, let's taper the steroids and give her Rituxan. So I gave her a dose of Rituxan, and then, a few weeks later, the EM comes out, and there are these mesangial deposits, and there's TRIs, and now we're like, okay, so this is now lupus membranous. So that's kind of the final diagnosis. So the case really just evolved, but fortunately, there is a role for Rituxan in treatment of lupus membranous. So I wasn't, wrong in giving her Rituxan, and I'm glad the audience agreed with me. So can I get the control for the mouse previewers? Just I just only have really 2 points because we have about 5 minutes left. But one is, you can, in rare occasions, see PLA2R in membranous lupus. As Dr. Rubin mentioned, this was a study that looked at patients. There were about 190 patients, and 37 of them had membranous lupus. And if you look at the next slide, if you look at the breakdown of positivity of anti-PLA2R, of the 37 patients who had biopsy-proven membranous lupus, about 20% of them actually had a positive PLA2R. We know the data shows about 75 to 80% of primary membranous patients have this. Non-membranous lupus nephritis, like class 3s and 4s, proliferative lesions, didn't really have. So this PLA2R is usually pretty negative in proliferative lupus. Non-renal lupus, very low percentage had a positive PLA2R, and historic controls obviously were 0. So we obviously use PLA2R as a marker of primary membranous, but in some cases of membranous lupus, not proliferative lupus, PLA2R can also be positive. So it's not out of the norm here that we had a positive case. Then the second question, so we called HEMONC and we said, what's going on with these lymphadenopathy on CT? They said, no, these have been there. They looked at prior CTs. They looked at their recent bone marrow. Everything looked fine. No evidence of, they were pretty convinced that there is no relapse. Now, as Dr. Corbett said, you can have nephrotic syndrome preceding the diagnosis of cancer. This person is in remission. So I'm hoping that this is not, well, first of all, this is membranous and not minimal change. So we're pretty convinced that, we were okay with immunosuppressing the patient because HEMONC felt pretty comfortable that there is no relapse of the lymphoma. Even if there was, Rituxan is actually part of the regimen of treatment of some of these lymphomas. So the patient got Rituxan on day 1 and day 15, and the data on treatment of membranous lupus with Rituxan is pretty rare. We actually don't have any randomized trials. We have a couple of studies, both of them are observational. One of them is an older study, about 50 patients. Unfortunately, that study had class 3, 4, and 5 patients in it, and they were getting MMF and steroids. So it's kind of a hodgepodge of patients. The second study, which is this particular study, is an observational study. It's only 15 patients, and they all had biopsy-proven lupus membranous. And just like our patients, they all had preserved kidney function, they had nephrotic proteinuria, and they all got Rituxan. And if you look at the rate of total remission at 6 months, at a year, and then 2 years, 80% of these patients responded with either complete or partial remission to Rituxan. And the good news is that the partial remitters actually ended up converting into complete remission as time went on, just like we see that it takes time for primary membranous to actually take effect. So just be patient with it. You know, if they haven't responded in 4 months, they probably will at 5 or 6 or 7 months. So that's kind of, you know, the data here. 15 patients, you know, 80% at 2 years with Rituxan is pretty good. So if this patient had primary membranous, or if this patient has lupus membranous, either way, it seems like Rituxan is a good choice. That's what she's got. I'm now convinced, based on the EM, that she does have lupus membranous. And many people have already said you don't have to have serologies. You don't have, you know, active serologies. You don't have to have the presenting symptoms you had at the time of prior presentation. You can have a renal limited membranous lupus without anything else systemically. And that seems like what this patient has. That's all I have.
That's all you have. No, that's a great discussion. You know, I think if there's a point here that I really like, it's the patients. We've learned so much about the patients you need with membranous. He said even at 6 months, you know, don't panic. Steve, what's the data? Not to put you on the spot, but I think you have a good idea of this. When do you start thinking about a treatment failure in proliferative lupus? 3 months? I mean, there's all these remission definitions based on proteinuria and everything else. So 6 months, that's not the 6 months, you'd be pretty worried, right? With a proliferative lupus.
Yeah, in the Euro lupus group actually looked at that. We've looked at our own data. I mean, you got to wait at least 6 months. It doesn't mean you have to be in remission. It's just that you should be seeing by 6 months at least some movement. You know, by 6 months, if you have, 20% complete remissions, you're doing well. I mean, it's not until a year that 50% of the patients with proliferative lupus go into remission, at least in our experience and actually in the experience of other people that have published. By 6 months, you'll see a partial remission in a fair number of patients. And so, if by 6 months you don't see some improvement, I would think that becomes a time that you might consider moving to another therapy, but you got to wait at least 6 months. And if you do see some improvement, you just have to kind of sit tight before you start jumping to another therapy. I think, and I don't know if this is what you're getting at, but, we often see, especially in second opinions, people are sending us patients who after 2 months haven't responded and they think they need to change the therapy. And I think the problem is you just have to sit tight. These things don't get better quickly. And in someone like this in particular, when you see that kind of intramembranous deposit, since we're measuring remission by proteinuria, you can bet it's going to take a while for that proteinuria to go back to less than whatever your definition is, 300 milligrams per day or 300 milligrams per gram. That's a lot of damage to the basement membranes. It's going to have to be kind of remodeled and reconstructed, but you should still see some improvement.
Do you remember from the collaborative study group lupus trial, and I'm talking about non-lupus membranous, I'm talking about proliferative lupus membranous. I know that the hematuria can take a year or so. I mean, that's one thing we've learned. You can have some microscopic hematuria for quite a while. Correct me if I'm wrong in a second, but the proteinuria, I mean, wouldn't you see a pretty good response by 6 months? Whereas 6 months with membranous, which is I think the point here, it's not necessarily panic time.
Say it again.
What is the timing of proteinuria reduction in class 3 and 4 lupus, non-membranous?
It's about, like I say, the partial remission rate is pretty good by 6 months.
Okay. That's exactly what I'm getting at.
And I thought that's what I was trying to say actually before, is maybe I didn't make myself clear, but the partial remission, at least, like say, by 6 months, over 60% of patients will be in partial remission. And whether you look at the Gensler data, the MMF, the MMF data that's out there, or our data, I mean, most of them were in partial remissions by 6 months. Very, 10 to 15% or 10 to 20% were in complete remissions, but partial remissions, which where basically, depending upon how you define it, it's usually a 50% decrease in proteinuria to below, oftentimes, if they're nephrotic, 3.5 grams. If they're not nephrotic, it's still 50%, but it's a 50% decrease generally is what some people will accept. But you'll at least see that, and that's why, you just have to be patient.
Yeah. Well, that's what I
Steve,
think
something you brought up, which is the exostosine story. I think that's an interesting tool that the Mayo Clinic group can help with, because if the patient tests positive for these markers, then that carries a good prognosis. So that's something else to take into consideration. And, I think Dr. Nasser takes tissue for their laser microdissection followed by mass spec analysis, and it could be helpful in this case.
No, that's a good point. And David's developed a nice relationship with them. And I don't know if he sent this tissue up there, but he could definitely do that. And they could stain for that. Those guys amaze me. Every time I turn around, I'm reading another article and they found another marker for something. The most recent thing is GVHD and membranous and this FAT1 molecule. And it's like, I can't keep them. The list just keeps getting longer.
Yeah, it really is. It's something to be said for when a group has that many, cases. They probably process 30 or so a day. It's like Arcana. It's really, they really have the ability to take everything to the next level. And I think what Dr. Rubin's point is really good, and that's something I hadn't quite realized, that the benign prognosis of exostosine-related membranous, it doesn't mean, I don't think it means you wouldn't treat this patient. It just means because this patient's very nephrotic and need a treatment, but at least long-term prognosis from a renal failure standpoint is probably pretty good.
Keep in mind, I don't mean to keep interrupting you, but Sloan, one of our fellows years ago with Mel Schwartz and myself, looked at all of our lupus membranous patients and basically found that the patients, in those days, membranous was divided into 5A, B, C, and D. And I know Mario will remember that. It was an older classification where it included the proliferative lesions under the category of membranous. And then after some of our data, actually with Chris Najafi, they flipped those proliferative membranuses into the proliferative categorization because they're, of course, kind of echoed or mirrored what the proliferative lesion was rather than membranous. But my point is that the patients that had what was considered a 5A, which would be this person, or 5B, which would be just mesangial membranous, they did very well. In general, they actually had an extremely good prognosis. So I think the histology here shows no scarring. And despite the fact the patient was amazing, it is impressive how nephrotic. This may have been evolving over a lot more time than we realized, but I think the prognosis, no matter what, should be fairly good for this person. And yes, hopefully the response to the Rituxan will be, what we hope it to be. Keep in mind, though, MMF, cyclophosphamide, calcineurin inhibitors would all be appropriate therapies as well. I think it's what people are used to. And I think many of us, Howard Austin showed that the cyclophosphamide and calcineurin inhibitors are definitely better than prednisone, which everybody knows. Prednisone is kind of passe in membranous period, no matter whether it's primary or secondary. But the MMF, which was Jay Radhakrishna's data with the MMF study that they had when he looked at that subgroup, it was a good therapy. It's just, I think most of us like Rituxan because it's just so damn easy to use, and the response rate so far has been good. But as Casey pointed out, importantly, the data in lupus membranous is not nearly as robust as it is in idiopathic. And I'll stop.
No, but boy, it sure is popular, and it's popular for a lot of reasons. And
I agree.
We all tend to project this idiopathic membranous to lupus membranous, and it's probably, I will be shocked if it isn't similar, but doesn't mean anything. I think I'm going to wrap this up. I want to thank everybody for coming. I want to thank Dr. Rubin for coming back. We missed you. You were in Spain, and we're glad to have you back. We're going to be off next week because even though we're off a lot of times because I'm out of town, and of course I don't believe we can run this without me, which is absolutely ridiculous. It's just me being me. We absolutely cannot run it without Praveer, who will be going next week. He's going to be in South Carolina enjoying the beach with his family. So we will be off next week. We should be back in 2 weeks. And until then, thanks everybody and stay safe.